At the end of this course, you'll be able to identify the BLS science and education updates, describe the rationale for the updates, and apply them during training. We'll start with the updated science for BLS. A new pediatric chain of survival was created for IHCA in infants, children, and adolescents. A sixth link, recovery, was added to all 4 chains of survival. The process of recovery from cardiac arrest extends long after the initial hospitalization. Support is needed during recovery to ensure optimal physical, cognitive, and emotional well-being and return to social or role functioning. This process should be initiated during the initial hospitalization and continue for as long as needed. The 2020 guidelines include an opioid-associated resuscitation emergency algorithm for trained rescuers, shown here. A version for lay rescuers is also included in the guidelines. Do not delay providing chest compressions for a pregnant woman in cardiac arrest. High-quality CPR can increase the mother's and the infant's chance of survival. If you do not perform CPR on a pregnant woman when needed, the lives of both the mother and the infant are at risk. Perform high-quality chest compressions for a pregnant woman in cardiac arrest as you would for any victim of cardiac arrest. Use an AED for a pregnant woman in cardiac arrest as you would for any victim of cardiac arrest. If the woman begins to move, speak, blink, or otherwise react, stop CPR and roll her onto her left side. A single rescuer may now use 2 thumbs or the heel of 1 hand for infant compressions. For infants, single rescuers, whether lay rescuers or healthcare providers, should compress the sternum with 2 fingers or 2 thumbs placed just below the nipple line. For infants, if the rescuer is unable to achieve guideline-recommended depths, at least 1/3 the diameter of the chest, it may be reasonable to use the heel of 1 hand. For infants and children with a pulse but absent or inadequate respiratory effort, it is reasonable to give 1 breath every 2 to 3 seconds, 20 to 30 breaths per minute. When performing CPR in infants and children with an advanced airway, it may be reasonable to target a respiratory rate range of 1 breath every 2 to 3 seconds, 20 to 30 breaths per minute, accounting for age and clinical condition. Rates exceeding these recommendations may compromise hemodynamics. It may be reasonable to use audiovisual feedback devices during CPR for real-time optimization of CPR performance. Debriefings and referral for follow-up for emotional support for lay rescuers, EMS providers, and hospital-based healthcare workers after a cardiac arrest event may be beneficial. To recognize a possible stroke, first aid providers can use the signs of weakness in the face, arm, or grip on one side of the body, or speech disturbance, and should activate emergency services as quickly as possible if any of these signs are present. While awaiting the arrival of emergency services, first aid providers may encourage alert adults experiencing non-traumatic chest pain to chew and swallow aspirin, unless the person experiencing pain has a known aspirin allergy or has been advised by a healthcare provider not to take aspirin. You've now learned the new BLS science updates. Let's check your understanding. The 2020 AHA Guidelines for CPR and ECC examines best practices in education and applies them to resuscitation science. In this section, we'll review the education updates related to BLS training. When implemented in training, these strategies raise the quality of care and increase survival from cardiac arrest. Incorporating a deliberate practice and mastery learning model into basic or advanced life support courses may be considered for improving skill acquisition and performance. It is recommended to implement booster sessions when using a massed learning approach for resuscitation training. It is reasonable to use a spaced learning approach in place of a massed learning approach for resuscitation training. It is reasonable for lay rescuers to receive training in responding to opioid overdose, including provision of naloxone. It is reasonable for EMS systems to monitor clinical personnel's exposure to resuscitation to ensure treating teams have members competent in the management of cardiac arrest cases. Competence of teams may be supported through staffing or training strategies. It is reasonable to increase bystander willingness to perform CPR through CPR training, mass CPR training, CPR awareness initiatives, and promotion of hands-only CPR.
Successful teams not only have medical expertise and mastery of resuscitation skills, but they also practice good communication skills and adhere to the key elements of effective team dynamics. Team dynamics is an element of high-performance teams and can be broken down into 3 categories: roles and responsibilities, what to communicate, and how to communicate. The ideal situation is when multiple rescuers work as a team to perform all the needed roles in a resuscitation attempt. This figure identifies 6 possible team roles for a resuscitation. Note that some roles are typically performed by advanced providers. If enough rescuers are present, each rescuer takes a role. A high-performing team achieves specific performance metrics, including a high chest compression fraction, or CCF. CCF is the amount of time spent doing high-quality chest compressions during a cardiac arrest resuscitation attempt. You can only achieve a high CCF by eliminating pauses during high-quality CPR.
The Resuscitation Outcomes Consortium trials, or ROC trials, showed that a 10% increase in CCF is roughly equal to an 11% increase in survival. Pauses typically occur during intubation, rhythm analysis, pulse checks, compressor switches, and defibrillation. The team member operating the AED, or the monitor defibrillator, can also serve as the CPR coach. The role of the CPR coach is to focus on team members' performance of high-quality CPR and to provide feedback as needed during the resuscitation attempt.